Next, I'd like to introduce Dr. Megan Miller. She is a physician in the Department of Obstetrics and Gynecology at Baystate Health and assistant professor of obstetrics and gynecology at the University of Massachusetts Medical School at Baystate.
Hi, my name is Megan Miller, and I am an OBGYN in the Generalist Division at Baystate Medical Center. I am also the primary physician at our Empower Clinic, where I see pregnant women with substance use disorders primarily. And today I'm going to talk about harm reduction in pregnancy. So I'm going to hope to discuss how stigma and bias can be intensified in pregnancy, understand the harms that are unique to opioid use disorder in pregnancy, and then discuss harm reduction strategies that are important in pregnancy and also in the first year postpartum. So just like the non-pregnant population, the prevalence of opioid use disorders in pregnancy has been increasing year over year since the early 2000s, which we can see in this graph. And Massachusetts is among the states with the highest prevalence of opioid use disorder in pregnant women. We're outstripped in this CDC data by only Vermont and West Virginia. So this makes it vitally important that we have excellent access to harm reduction and treatment strategies for opioid use disorder in pregnancy. So the first thing I wanted to talk about was how stigma and bias can be intensified in pregnancy and for women with substance use disorders. So we know that substance use disorders or people with substance use disorders are significantly affected by stigma and bias. And in pregnancy, this can really be magnified. Society rewards pregnant women in traditional gender roles, and this has been shown in multiple studies that have shown pregnant women in the workplace tend to receive poorer evaluations than men or non-pregnant women. And often this bias can lead women to leave the workforce either during or after pregnancy. And drug use in pregnancy is often viewed as a gender failure. And people can see this as a failure to conform to the gender norms of pregnancy, where women are basically protecting their newborn. And because they're using drugs, they're seen as unfit or dangerous mothers. And on top of this societal stigma, these women tend to have internalized stigma because they know what they're doing isn't safe for themselves or their baby. So they tend to have guilt and shame over the risks associated with drug use in pregnancy. And this stigma and bias can have significant consequences. So we tend to see it in late or inconsistent presentation to care, and that can be prenatal care, medications for opioid use disorder, as well as community resources. These women also tend to have a significant amount of shame and guilt, like I just talked about, and this can lead to decreased self-efficacy and autonomy in care. We tend to do a lot of shared decision-making in pregnancy, and when women feel like they're lesser than or not doing a good job at being pregnant, they tend to be less engaged in that process, and that can lead to poorer outcomes. They also may avoid or stop medications for opioid use disorder in order to decrease the risk to the baby of things like neonatal abstinence syndrome or to avoid DCF involvement. And as we know, avoiding or stopping medications can increase the risk of relapse and overdose. So I want to talk about the harms that are unique to pregnant women. And these are not all unique to pregnant women, but they can be higher risk. And I want to talk about how that can affect them. So the ones I'm going to focus on are overdose and death and untreated mental illness. The two harms that are very specific to pregnancy that I'm not going to cover significantly are neonatal opioid withdrawal syndrome, also known as NAS or neonatal abstinence syndrome, which is the withdrawal that babies go through after they're born when women are on opiates. And then the last one is loss of child custody, which can be a significant stressor for this population and can affect the way that women are engaged in prenatal care and how they fare afterwards. So this graph is showing the proportion of pregnancy-associated deaths that are related to substance use by year of death. And as you can see, since 2011, the proportion of deaths that are related to substance use has been increasing year over year. And in 2014, 1 in 5 pregnancy-associated deaths in Massachusetts was associated with substance use. In similar data from Maryland in 2014, unintentional overdose and substance use was the leading cause of pregnancy-associated deaths. There are multiple factors associated with overdose, and two that I'm going to highlight later on that are really important because they're both common and also treatable are anxiety and depression. But young women who are single, unemployed, who have inadequate prenatal care or are homeless, and have a history of prior non-fatal overdose are higher risk, as are women with neonates who had NAS or had high unscheduled healthcare utilization. And the timing of these overdose deaths is interesting because we don't always think about it as a significant contributor to pregnancy-associated deaths because it doesn't happen during the period of time when we tend to see pregnancy-associated deaths, which tends to be in that first 6 weeks postpartum before we see patients for their quote-unquote postpartum visit. We tend to see these, the likelihood of death being associated with substance use happening after that 6-week visit and up to 1 year postpartum. And this underscores the importance that we continue to follow up with these women postpartum beyond that 6 weeks to make sure that they're remaining in care, staying on their medications, and staying safe. Again, this is data from Massachusetts that is basically showing what we know, which is that pregnancy is a time of opportunity when women tend to get into care. You can see that the risk of overdose in the 2nd and 3rd trimester is much lower than prior to pregnancy and also following pregnancy. But the other important thing to note is that that 7 to 9 month mark, so getting past that 6-month mark, is where we see a spike in overdose and overdose deaths. In this study, there were 242 overdose events, and 11 of them were fatal. And it's important to note that although we see these increases in overdoses postpartum, there are ways to prevent them. So what we already know is that medications for opioid use disorder decrease the risk of relapse and subsequently overdose. And we can see here that the orange bars being overdose events on pharmacotherapy, the gray bars being overdose events not on pharmacotherapy, and the likelihood of overdose is much less likely if a woman is on pharmacotherapy versus not. And this in this study reached statistical significance at the 4 to 6 month mark. And this tends to be when women, again, are no longer being seen for prenatal care. They tend to be possibly losing insurance, may have lost custody. And again, it shows how important it is to maintain women in care for that period of time postpartum. So I did want to talk a little bit about medications for opioid use disorder and pregnancy. They can be used to reach multiple goals, some of which are treatment and harm reduction, decreasing the risk of relapse and overdose. And we also think about it as well in pregnancy to avoid moderate and severe withdrawal, which can affect mom and increase her likelihood of use, but also affect baby. The choice of medication should be driven by patient preference in the absence of medical contraindication, and we feel very strongly about that. Methadone was historically the first-line option in pregnancy, and we find that inpatient admission is ideal for expedited dose stabilization in pregnancy, so women don't continue to feel the need to use while they're slowly getting up-titrated. Buprenorphine is also now considered a first-line option. And historically, the buprenorphine monoproduct was primarily used in pregnancy, but now, as of the most recent ASAM guidelines, buprenorphine and naloxone is considered safe and effective in pregnancy. The reason we weren't using buprenorphine and naloxone previously is essentially twofold. The first reason is because if used inappropriately, so IV or insufflated, it can cause some withdrawal, and people didn't want pregnant women going through withdrawal. And I find this quite a paternalistic way of thinking. There's no reason to assume that pregnant women would use it appropriately any differently than anyone else. And then the second reason was the concern for the effect of naloxone on the neonate because we didn't have safety information. But as most of us know, if used appropriately, the dose of naloxone from buprenorphine and naloxone is really quite minuscule and not clinically significant compared to the levels of buprenorphine and its breakdown product norbuprenorphine. So theoretically, it doesn't make much sense that this would cause a significant effect on the newborn. And our data has borne that out. So there have been now multiple studies looking at buprenorphine naloxone in pregnancy, and it has been found to be safe. It has lower rates of NAS compared with methadone, lower rates of NICU admission compared with buprenorphine. It's been found to have no difference in NAS compared with buprenorphine monoproduct, no difference in APGAR score or C-section rate when compared to no opioid, and no difference in neonatal or maternal outcomes compared to the monoproduct. So I'll say it again, buprenorphine and naloxone is safe and effective in pregnancy and can be used as a first-line agent. That's what we're doing here, and that's what many of the major centers are doing as well. So how can we further incorporate harm reduction into OUD treatment, in addition to making sure that patients are on effective effective medications? So we want to discuss safe illicit use, and I do this with my patients early and often through prenatal care. We discuss safe injection techniques, encourage the use of needle exchanges, and then hopefully by the end of the year, we'll be offering our patients harm reduction kits, whether that's in the outpatient or inpatient setting. We also want to talk about overdose prevention, and this is especially important as prior to the postpartum discharge. Just as we discussed, the risk of overdose increases during that period of time, so we want to make sure that patients understand that many of them have been abstinent for a long period of time, which means that if they do use and go back to using what they were using before, they can have an overdose and it could lead to death. So we want to make sure that they understand that they have a Narcan or Naloxone prescription or Narcan in hand, and that they're using with another person so that if they do overdose, they can get help. We also always talk about safe sex and pregnancy prevention. This population has a high risk of unintended pregnancy, and we want to try to prevent another pregnancy until a patient is ready to parent again, to give them a chance to really be a parent to that child. We will offer expedited start of long-acting reversible contraceptive in postpartum. So we'll do that in the hospital, so they don't have to worry about necessarily getting to an in-person visit, especially during COVID. And the LARCs are things like the IUDs and the Nexplanons, which act for a long period of time and are very effective. We also encourage condom use to decrease the risk of STDs like HIV. And I think the most crucial thing is making sure that patients continue to have close follow-up beyond that 6-week postpartum visit we tend to think about. So that's close follow-up for at least the first 6 months postpartum, because we know the risk of overdose spikes at that 4 to 6 month mark, and then continued follow-up for at least 1 year postpartum, and they should be on medications for at least that period of time. And this is a graphic from the Journey Recovery Project, which is a website that Massachusetts has made for pregnant women with opioid use disorder that brings them through that entire period of time. And so this is something I think is crucially important for this population. So like I said, I do want to get back to talking a bit about mood disorders, because we know that anxiety and depression are much more likely in the population with overdoses, more so than the population of patients with opioid use disorder with no overdose. And these are factors that can be diagnosed, treated to hopefully decrease that risk. So we do know that patients with opioid use disorder do have a higher risk of anxiety, depression, PTSD, and bipolar disorder. And having these disorders makes them predisposed to postpartum mood disorders as well. Postpartum depression and anxiety are defined as major or minor depressive episodes within the first 12 months after delivery. And anxiety and insomnia tend to be prominent features. Unfortunately, it often goes unrecognized because the symptoms could coincide with symptoms they have from their primary mood disorder, or some people just may not be screening for it. Something scary that is also going to be higher risk in this population is postpartum psychosis, which can result in suicidal and homicidal ideations. And women with bipolar disorder are particularly high risk. And if they have a family history of postpartum psychosis, they actually have a 74% risk of developing this. So it's extremely important that women with bipolar disorder be closely monitored for mood disorders postpartum. So we do this by screening all women in pregnancy and postpartum for postpartum depression, and we use the Edinburgh Postpartum Depression Scale, which you can see here. And then we want to offer treatment, which can include referral to mental health providers, therapy, and medications like SSRIs. And we want to make sure we're giving close follow-up so we can monitor their response. McPack for Moms is an excellent resource, especially for patients who are more complex, like our patients with PTSD or bipolar disorder, where we don't necessarily want to start an SSRI because it may, it may throw them into mania. Patients with more complex disorders like schizophrenia and things like that, they can do doc-to-doc consults, or they can also do face-to-face or now virtual consults with patients to make sure that they're getting the appropriate care, and then we can be prescribers. So it's an excellent resource that Massachusetts has, and we're really lucky to have it. So, in conclusion, stigma and bias are intensified for women with substance use disorders and pregnancy. Pregnancy is a time of opportunity, but also risk for women with substance use disorders. The first year postpartum is particularly high risk for relapse, overdose, and death. And buprenorphine and naloxone is a safe and effective medication for OUD and pregnancy. And then important harm reduction strategies I want to highlight include initiation and maintenance of MOUD in pregnancy and postpartum for at least 1 year, education on safe injection techniques, overdose avoidance and management, safe sex and contraception, and diagnosis and treatment of baseline and postpartum mood disorders.
Key points from Dr. Miller's talk. The postpartum period presents elevated risk of relapse and overdose. Having a mother engaged in treatment is the best path to address future interactions with regulatory agencies like DCF, and Suboxone is considered safe during pregnancy.